right, what I want to do now is stop. Because, as I said, we can go on probably for years. It's a fascinating, it's a multi-level problem, but we just don't have an infinity of time over here. So what I would like you each to do is spend about 30 seconds. Sum up, if you will, one comment you'd like to leave with our viewers. And let's start with you, Chris.
I would say to our audience that despite all the problems with pain management and opioid pharmacotherapy, chronic pain is way undertreated, underdiagnosed, undertreated, and it needs to occur in the primary care setting as early as possible before significant chronic pain, neuroplastic imprinting occurs. So it's in your offices, and you have the opportunity to educate yourself at the onset and then treat it early on in a multi-mechanistic fashion.
Jeff?
Agreed with Chris. I'll come at it from a little bit different standpoint for those primary care and pain clinicians out there that aren't routinely screening and monitoring your patients. There is a standard in pain management. If you're going to use controlled substances, you have a responsibility to use them safely and appropriately. You must do a comprehensive history and physical exam on your patient. You must communicate with the referring physician. You must review old records. And critical and landscape changing to the way we monitor patients is look at their urine drugs for the medications that you're prescribing, and for any illicit substances. Have that medication treatment agreement that we briefly mentioned here, and by all means, you have it at your fingertips. I think there's only one state that doesn't have it. Log in, get a username and password for your state's prescription drug monitoring program, so you can know where your patients are getting medications at all times.
Joe, I'm going to give you the last word, understanding that going last sometimes is hard if they take all the good stuff.
Yeah, those guys are great. I mean, as I said, we all like the word multi. If you do chronic pain medicine, you can put multi in front of anything and it tastes good. So, you know, multimodal, multidisciplinary, multi-mechanistic analgesic routes, etc. Don't forget that, again, these patients don't have much of a voice. Chronic pain patients themselves they're in a miserable situation. You have to treat them looking at quality of life, activities of daily living, functionality. Those have to become paramount. The more that you can educate your patient, the more that they can buy into their chronic disease state. I think the better compliant patient you have and the better outcomes you're going to have. And chronic pain, unfortunately, from a point prevalence standpoint, is only going to get larger. Primary care doctors are going to need to adopt these skills earlier. They're going to need to come up with their own gestalt of when they're going to refer to chronic pain specialists, because there aren't a lot of chronic pain specialists out there, at least when we look at the magnitude of chronic pain from a point prevalence in the United States.
Well, I want to thank all of you for being here with me today. Dr. Agar, thank you for joining us remotely. On behalf of everybody involved with this broadcast, I want to thank you, our audience. I hope you found our exchange useful and informative. I'm Dr. Peter Salgo. We'll see you again.